right. Good afternoon, everyone. Really excited about this webinar and having our moderator and panelists talk to the 300 plus people that have joined, that wants to join us today and talk about 340B, which will be led by Mr. Jen Laws. He is actually in one of my mom's hometown, Slidell, Louisiana, to talk about this issue. So we're coming all the way to you today from Paris to France to New Orleans area to Slidell, Louisiana, and everywhere in between. So without further ado, I guess I turn it right over to Jen to start this conversation.
Good morning or afternoon, everyone, depending on where you're at. My name is Jen Laws. I am the president and CEO of Community Access National Network. I am a transgender man living right outside of New Orleans in Slidell, Louisiana. Thank you for that introduction, Brandon. I am also living with HIV. So these personal details kind of help tell our stories as to why these things are important for us. And I am really grateful to our event sponsors for this webinar and for our hosts over at NMQF. I am also really kind of excited to have our panelists with us today. So I'm going to ask them to introduce themselves, include a little story about who they are, because none of our data means anything without the actual human beings behind it. So let's start off with Dr. Udo.
Good morning or good afternoon, everyone. I'm here based in California. My name is Ifoma Udo, she, her pronouns. I'm the Executive Vice President for Policy Advocacy and Science at Black Women's Health Imperative. Black Women's Health Imperative, as many people on this call might know, is the singular organization in the United States that holds the depth and the breadth of policy, advocacy, research, and science for the 21 million Black women and girls in the United States. This is our 40th year that we've been in existence. I'm so excited to be here. I come to this conversation and this work really from the perspective of having been someone who spent 25 years of my career doing research and evaluation, particularly around HIV, sexual reproductive health, maternal child health issues. And having moved into this sort of policy wonk place in my career, which is really weird. Weird is a really famous word right now in our policy landscape, by the way. But it's been really fascinating to me to be a researcher in this space and to move into a policy place where policies we know should be driven by data and science, and sometimes those two get disconnected. And one of the things that I know that works in the 340B drug pricing program, particularly from my experience of having worked in the HIV world, is that when this policy is transparent and it is operating well, and our communities can access their medications through wraparound services in clinics that place the center of care for people who are living with HIV for their partners, that we know that it provides a way to address disparities in access to medication. And I come to this work wanting to see that continuum of care happen across all communities in the United States. So I'm really happy to be here and to be with my colleagues on this call today.
Fabulous. Thank you so much, Dr. Udo. Lizzie Whitting from Tiger Lily is also joining us. Hi, Lizzie. Why don't you introduce yourself?
Hi, thank you, Jen. I'm Lizzie Wittig. I'm the director of the HEAL Policy Center of Excellence at Tiger Lily Foundation. We are a women's health and oncology organization branching out from breast cancer originally. And that is where my experience comes from in this space, and actually have been in the patient advocacy and starting in breast cancer advocacy for about 19 years now, because my own mom was diagnosed with breast cancer. When I was 16, I became a caregiver at that age, and just trying to help, single mom, only child. It was just us seeing that barriers that we were coming up against and trying to navigate that care got me really interested in figuring out how policies and policy making can help in those ways, making systemic changes, changing those access and eradicating barriers. And so that's where I got started in this work. I've been with Tiger Lily for about 3 years now. I'm really excited to be here and be focusing on health equity and our specific focus of alleviating disparities of age, stage, and color. So focusing on young metastatic or advanced disease and brown and Black patients and community members. So we are really excited to be here today. And thank you again to NMQF and Jen and sponsors for having us. And our viewpoint here for 340B, to echo some of what Dr. Udo was just saying, for us, it comes down to the patient impact and the benefits that patients actually get. And so whether a program is good or bad, if it's functioning in a way that's helping patients, and we'll talk about some of those things and solutions and that Dr. Udo mentioned as well, that's what we're here about. So thanks again for having us.
Fabulous. Thank you. Thank you. All right. Our next panelist is Robin Strongen.
Hi, everybody. I'm Robin Strongen, and I run the health policy work for the National Consumers League, which is a nonprofit based in DC. We're about to celebrate our 125th anniversary. We were founded by two very feisty women, social reformers, and two of the pillars that really are a through line through all of the work since its formation and bringing us up to today, and the issue we'll be discussing today, are the commitment to fairness in the marketplace and consumer protection. And so clearly this has implications for the webinar here today. I've been doing this work here in DC for over 40 years. I've been on and off the Hill, in and out of HHS and everywhere else. And one of the things that I think is essential for solving the types of policy challenges that at the end of the day are life and death for people, for individuals, are the ability to work across with all, I hate the word stakeholders, but everybody. Everyone brings something to the table, and I'm really delighted to be able to be here to help share some of the work that we're doing at National Consumers League to see how we could help move things forward for a really terrific program that has just kind of gone off the rails. But I think with a lot of unified action, we can get it back on track and ultimately do what it was intended to do and help the people it was designed to serve and help. So there you have it.
Fabulous. Thank you, Robin. Y'all might notice there's a lot of love and empathy involved in this discussion and where folks are coming from, which leads me to our final panelist, the ever fabulous Reverend Kimberly Williams.
Thank you, Jen, and to all of the panelists. It's a pleasure to be here. Good afternoon, everyone. I am Reverend Kimberly Williams, and I am the Executive Director of Choose Healthy Life. And our organization marries faith and science to bring resources, education, and awareness to our communities through the trusted voice of the Black Church. We were founded by Deborah Fraser Howes, who was known for her work with the National Black Leadership Commission on AIDS, BLACA, and she was very instrumental of removing the stigma between faith and HIV/AIDS back in the day. And so after seeing Black and brown bodies being put into Black bags, going into Black refrigerators during the COVID season, she founded Choose Healthy Life. And Choose Healthy Life is so concerned about ensuring that our participants receive care and understand that prosperity starts with your health and your wellness, where we are definitely believers and we are founded on a foundation of faith and science. We believe that that faith should extend into your health and wellness. And so we are excited about the opportunity to be here. I am the granddaughter and a third generation preacher to one who had 15 children. And my grandfather died of a heart attack in the pulpit. And so some of the death that I've experienced within my family has been due to fear, due to lack of resources, and due to the education and awareness of how to really take care of themselves and move in this journey and understand that human right is human health. I mean, you can't do anything else in the world without your health. And so it's a pleasure to be a part of this discussion today as in this role. Thank you.
Reverend Williams, I got to tell you how much I appreciate that. Regardless of our faith journeys, all faiths across the globe call us to take care of and love one another and help each other in healing and overcoming illness and really kind of creating equity, right? Like, so we're going to bring it back around to the topic. I'm going to level set a little bit and talk about some of the history of 340B and its role in pushing our efforts around health equity. So in 1992, Congress kind of sat down with manufacturers and said, hey, we know that some of y'all are doing some voluntary discounts and stuff, but like you could maybe have a larger like consumer base through Medicare and Medicaid if we kind of formalize and standardize these rebate programs. And the idea here is to kind of stretch those dollars by re-implementing and reinvesting those rebate dollars into these programs that are designed to serve underserved communities. And we know underserved is kind of code for Black and Brown women, LGBTQ plus, disabled persons, marginalized and minoritized communities. So that's really kind of like the intent behind 340B. And as we go through this, I'm going to encourage everybody to use the chat box. If you've got commentary, if you've got specific questions, please go ahead and use the Q&A box. And this way we can kind of distinguish between commentary and conversation and questions for our panelists. So 340B is this really powerful tool when we talk about this. We're talking about today more than 120 billion dollars annual. That's huge and it's growing. And there's this piece where, okay, if this is your sales, where is it being reinvested to really serve its intent, which is furthering the value and the service offered, and through a variety of different mechanisms for marginalized communities, stretching these federal resources that are meant to improve public health. And there are specifically named grantees in that space that are qualified through 340B. There are also hospitals. There are other private interests that have found themselves as mechanisms in 340B, like contract pharmacies or pharmacy benefit managers, or third-party administrators. And so there's these fingers in 340B, right? And not a lot of patients are very familiar with 340B or its power in achieving health equity, in part because these private enterprises involved and have kind of pulled the program in, right? We know when there are public service dollars available, private interests, when that becomes the mechanism for it, make sure they get theirs. And oftentimes that comes at the expense of achieving health equity. Think about this. We've got $156 billion from this program. Where's it being reinvested? Where are we seeing this? Why are we not seeing health disparities improve? It's powerful, powerful funding. This is life-changing funding in highly affected communities and in marginalized states. And I mean truly marginalized states, because we look at health disparities across the South, for example, and they're enormous, enormous. And so you'll notice that there was conversation between two of our panelists, specifically Reverend Williams and Dr. Udo, mentioning HIV. And I've got to be very clear, Community Access National Network is HIV-oriented inpatient advocacy. And the reason we bring that up, and there you're going to hear a lot about that intersection, is because one of the most transparent spaces that we see 340B operate is through Ryan White. The federal Ryan White program is our nationalized HIV service program. Specifically, the only payer specifically named as a grantee in 340B is the AIDS drug assistance programs. And they look a little bit different from state to state, kind of like Medicaid programs. But there's incredible transparency. Every single dollar must be reinvested back into the program to extend access to free, and I mean free, no cost to patient or community member, no cost to qualifying participant in 340B to have access to their life-saving medication. This is a gold standard, and there's a reason it's a gold standard. We have been able to make extraordinary strides in combating HIV as it affects marginalized communities, specifically because the Ryan White program and the AIDS drug assistance programs as models. So we've really got to kind of figure out how to duplicate that, right? And that's really part of where this goes. So I want to move on to involving our panelists a little bit more. Dr. Udo, who and what are some of the problem actors or barriers to health equity that you're seeing in 340B?
Yeah, I mean, I thank you so much for the question. And thank you also so much for giving that context because there is a gold standard around how 340B can be used. And we do have models that work. And so with $156 billion, there's so much more that we can do with that across many of the health disparities that exist in the United States. When we talk about the maternal health crisis in the United States, when we talk about cardiovascular disease, cancer, the epidemics in that space. There's so much more that we could do if we had the gold standard of care around thinking about where those benefits lie. And right now, one of the challenges I think that exist with who is profiting currently is about this issue of transparency and where the reporting is coming from. Unfortunately, there's a bit of a gap in how the mandates create reporting structures in that FQHCs, federally qualified health clinics, and other public care centers are specifically required to report on what they are doing with the benefits of their 340B drug pricing. And those requirements are not in the same way in place for private manufacturers, private hospitals, the PMBs. I think there's a question in place around in the chat right now about pharmacy benefit management programs. And so one of the things that we have to do is close that gap. We have to close that gap in ensuring that reporting is done across the entities that are benefiting from that. With $156 billion, we can address maternity deserts in the South. With $156 billion, we can address access to expensive cancer medications, which I know our colleague here from Tiger is going to speak about. And so I think when we talk about who is benefiting, who should be benefiting is our communities, who should be benefiting are Black women, who should be benefiting are brown and Black folks who have lack of access to insurance, who have challenges getting to their local healthcare providers, where it takes 75 miles for you to get to a hospital or a clinic. There needs to be transport services involved to support, that kind of care. There needs to be patient navigation services involved. 340B drug pricing has helped secure coverage of that kind of care and when it's used well. You see social workers being brought into federally qualified health clinics. You see more supportive systems being brought into federally qualified health clinics. And we want to see that same sort of translation of services to close that gap in disparities for care across the board. So it should be benefiting all of us.
Fabulous. Thank you so much, Dr. Udo. Lizzie, Dr. Udo brought up some really interesting points around reproductive health. And there's a deep intersection between HIV and the FQHCs that kind of serve our communities, especially here in the South. There was a really interesting study done some while back, a data analysis in Alabama among Black women and the intersection of rural health and cervical cancer and higher rates of mortality involved in that. Yeah. Can you talk to us a little bit about the role 340B? Lizzie, can you talk to us a little bit about the role in 340B and maybe kind of helping close those gaps and where it's not happening?
Yeah, sure. Thank you, John. I think when we're talking about the kind of unique impact of 340B on cancer, we think a lot about hospitals. That's where oncologists mostly are. And we think about, or we know and see that, almost half of all targeted oncology drugs are part of the 340B program. And thinking about that's a large percentage of the cancer community then. And as you're mentioning these kind of studies in Alabama, there have been some in North Carolina and others as well. For us, it's kind of an acute impact for the oncology community. And part of that is looking at, the intent of this program to bring health equity, to bring these kind of charity programs or patient support services into these communities where it is lower income and higher rates of uninsured, underinsured communities. And as you said before, that can kind of be code for our Black and Brown communities. So the issue we see here a lot of times is when that has expanded, rapidly recently in the last, I want to say 2 or 3 decades, but if these options in hospitals that are enrolled in 340B, only, I think, less than a third of them are in these actual medically underserved communities. And so that is something where you're talking about 2 of 3 hospitals in the US are part of this program, but less than a third of them are in the communities that are actually supposed to be getting these services and that this program was originally intended for. That creates a huge gap, right? And creates a lot of additional disparities. One of the things in talking about South 2 with North Carolina, that study with, I should have checked, but looking at, I'm sorry, the North Carolina State Treasurer, thank you, I'm sorry. But looking at that report, things that came out of that, like state employees being charged price markups of over 5 times on outpatient oncology infusion drugs. So, infusion centers where patients go, charging over 12 times what their discounted costs for those 340B infusion oncology drugs were. And then contracting with pharmacies in wealthier communities, which, on average or generally have fewer uninsured residents and lower percentage of Black residents and lower percentage of low income residents. Those benefits are going out of the community then, and they're not where they need to be. So we hear stories sometimes of patients going to, in their communities, they might have a community oncology center closer to them and a hospital, and both could be 340B participants. And the patient sometimes will go to the hospital and be turned away because they have a quota for those kinds of patients that are not insured, would need the financial assistance and the other programs there, and end up going back to the oncology center who's seeing them. So, when we're getting stories like that and we're seeing reports like this come out, it's blaringly obvious that this program is not addressing across the board the way it should be the health disparities and helping us achieve health equity. And so that's for us where we're trying to look at. And I think part of that gap and kind of the solution as we're talking about today is making sure that we're really including these patient experiences into the kind of updating and creation of programs like this. So, one thing that we talk about a lot with Tiger Lily and with a lot of you here on the panel today is, how do we take those patient experiences and those patient voices and use them to better these programs or to co-create new programs? And then how do we keep that continuous feedback loop so that we're continuing to look at how these changes or updates or expansion of programs, like in this case, are affecting the real world impact of patients, and how do we make sure that that is protected and is our first priority moving forward? I think I went a lot off topic. I'm sorry. I'll be quiet.
No, Lizzie, that was fabulous. And thank you. It really kind of puts some context on things. I really want to highlight that you mentioned that infusion centers and hospitals kind of like increasing their supposed charge rate in order to get more back on the 340B side. And that's there's this idea that 340B doesn't result in increased cost to taxpayers, but that's not true when we look at things like overall like list prices and things like that, and prescriptions. And when it comes to prescriptions, like especially as they're built into hospital systems, right, and hospital billing and things like that, we start looking at things like medical debt, right? And so 340B should have a role in balancing medical debt and charity care and things like that. But there's more than $220 billion of medical debt right now in the United States, and it's growing. There's more people who experience that. About 80% of medical debt comes from hospitals, though, and that has a huge role to play in this. So, Robin, can you talk to us about medical debt, charity care, 340B's role, and what it should look like in your ideal versus what it is happening?
Sure. So I think where I'd like to start is we, National Consumers League, have a program that we call Script Your Future, and it's all about medication adherence. It's a national education campaign. Across the country, we work with schools of pharmacy. They're able to go deep into local communities, talk with patients, caregivers, consumers, and nonpartisan. It's a win-win. We're about to start our 14th cycle. The tagline for this program, in short, is you can adhere to what you can't access. So access barriers, no matter how well-intentioned, really are a stumbling block for people, caregivers, loved ones to try to stay with a treatment plan that their health provider is recommending. And medical debt is one such barrier to access. And we are particularly and increasingly outraged and concerned about hospital abusive and aggressive debt collection practices and how these lead to consumer medical debt. I also want to take a minute and say that there are a lot of hospitals who are doing great work in this space. I do not mean to suggest that it is all hospitals, but the trend is disturbing. The numbers we're seeing, the egregious injustice and unfairness and driving trucks through unintended program lack of clarity and so on and so forth is outrageous. So again, not painting everyone with the same brush, but there is a very large cautionary tale to be had with a lot of data to back it up. Some of these tactics include garnishment of wages, putting liens on people's homes, sending bills to collection, requiring people use their credit card, which starts a whole cycle of all kinds of trouble, and worst of all, care denial. For another conversation, for another webinar, but related to this whole issue, is our focus on nonprofit hospitals, charity care, and how much they should be delivering back to the communities in exchange for the nonprofit status and the very large tax breaks that some of these hospitals are receiving for plan, number 2. But we are very troubled. Just a couple of, data points. As of 2021, 58% of debts recorded in collections were for medical bills. This is according to the Consumer Financial Protection Bureau. And it's gotten so bad and so out of hand that according to the Urban Institute, the link between sickness and debt is now a defining feature of the US healthcare system. I mean, that's pathetic. Urban analyzed credit records and other demographic data on poverty, race, and health status. And US counties with the highest share of residents with multiple chronic conditions, so super sick people, cancer, other very significant chronic conditions, also tend to have the most medical debt. So what does this mean? This makes illness the strongest predictor of medical debt, stronger than either poverty or insurance. Third way, just issued this year back in March, so March of 2024, a memo on medical debt where they found, not surprisingly, that the average debt for medical care is increasing. It actually falls most frequently on the middle class. However, the average medical debt among those in the poorest quintile exceeds their income, and it exceeds 40% of the annual income for those in the second quintile. And medical debt is highest among racial and ethnic groups who lack health insurance. So programs like 340B can and were intended to help the very patients who need help accessing their medicines, because remember, Script Your Future, you can adhere to what you can access. Medical debt is putting up an enormous barrier, and the lack of clarity, the weak accountability, the greedy, entitled, exploiting loopholes, they're really taking advantage of and profiting off of the very patients, consumers that the 340B program was designed to help. So what's a consumer to do? NCL is a proud member of an organization called ASAP 340B, which stands for the Alliance to Save America's 340B program. They have great resources. You could look it up at asap340b.org. And to keep that program true to the safety net program that it was intended to, we strongly support the principles of ASAP 340B, particularly to ensure that 340B prescriptions are offered to patients at a discount, to update the 340B patient definition with strong safeguards, establish clear criteria for 340B contract pharmacy arrangements to improve access, to update and strengthen hospital eligibility criteria. And finally, to prevent PBMs, pharmacy benefit managers, and other for-profit entities from profiting off of this 340B program. And of course, for crying out loud, to abolish and prevent medical debt and the predatory practices that harm patients.
Thank you, Robin. That was really insightful, especially when we look at the idea and really the data around medical debt and where that's concentrated. That's like massive, right? So, and that brings me to wanting to ask Reverend Williams, what role does medical, so let me back up a little bit. Health equity is a very clear goal, right? But there are layers on how we get there and where those disparities might occur, right? And one of those things is medical and medical system distrust among marginalized and minoritized communities. So what role does medical debt play in those trust issues, and what role could 340B be used to help kind of solve them?
I think I kind of missed the end there, Jen. Are you still there?
I am. So what role could 340B play in helping deal with that?
As a clergy member, and when we speak to the trust, right? The trust is broken a lot of times because when you think about how expensive drugs are at this time, what you see is people are challenged with making a choice. When you think about the social determinants of health, the hierarchy of needs, if I have to choose between my food and my prescription, more than likely I'm going for the food. If I'm choosing between lights, air, heat, and my drugs, we found a lot of times that our participants were suffering because they could not purchase their medication and care for their immediate needs. And so we see firsthand how, the drug costs really impact our communities, and they struggle when they're deprived of these medications. It played a huge role in those pre-existing conditions that we saw, where if you can't manage your blood pressure, if you can't manage your diabetes, if you don't have the medication that you need for your health, it really has a huge impact. And so I would say that it's due to some of the shortcomings that we're seeing when it comes to how some organizations are benefiting from 340B instead of it going back and helping to support the community. And so where it was supposed to help them to get their medication, in fact, we're seeing the exact opposite. And so we believe at Choose Healthy Life, that the health equity is necessary because the ability to meet needs within our community is an expansion of health equity. And so they have to be able to have the access. They need to be able to have their broader needs when it comes to their social determinants of health be met. And when we see some of the failures that we see with 340B, it makes it harder for organizations like myself to stay on mission, because we're really trying to help support with so many needs that those fundamental needs are not met. So the importance of what we're doing, and I think how we help, is through the collaboration. It's through these types of discussions. It's with our healthcare providers, our policymakers, in order to look for unique ways to build out solutions. And so we want to help with ensuring that we can mitigate those unintended consequences of the 340B program to protect the health of our communities. So ideally, it's very important for this to work so that our participants don't have to choose, and that they can definitely have it all when it comes to their medication, their care, and their social determinants of health being met within the community.
That's fabulous. Thank you so much, Reverend Williams. I'm going to encourage our panelists to go ahead and drop their email addresses into the chat so that everybody can see it. Because we've got several questions there. We've got some that we had discussed ahead of time as being interesting spaces, and we're running a little short on time. That's the nature of these things, but we do want to make sure that we're accessible for follow-up. Okay. We're highly invested in everybody's input here and looking for collaborative solutions on that. But talking about solutions and looking at these spaces, can each of our panelists take a little bit of time, a few minutes each, to talk about where you think, like, specific ideas on where 340B can be improved, what kind of reforms you want to see, and how that's going to help your communities?
Yeah, I'll take a crack at that, and really want to hear from my other colleagues on this call as well. A really big push in the advocacy efforts that BWHI has been focusing on in this space is that the requirements around how 340B drug benefits are being used should be required across the board. As our colleague from Tiger Lily spoke of, right now you have 2 to 3 in every congressional district. There are hospitals that are eligible for 340B. In every congressional district in the United States, hospitals and clinics are available and can access 340B. But the only hospitals and clinics that are reporting to what they're doing with the discounts from 340B are those that are in public settings. Private hospitals and PMBs are not required to report to the same level as transparency as the public entities are. That seems really unfair to me. It seems like we're really distinctly trying to penalize communities and people who only can access their services at federally qualified health centers or public settings. What's happening with those private hospitals? They need to be held to the level of standard as everybody else in terms of what they are doing with the benefit that they are receiving from using 340B drug pricing. And so we really are strongly advocating for our congressional leaders and our policymakers to push on that level of transparency and reporting. Where is the money? How much did you get? What did you do with it when you got it? Did you use it to set up transportation services? Did you use it to fully staff your social workers in the hospitals? Did you use it to close health gaps? Particularly, again, when we talk about the devastating health deserts and the health disparities that we're seeing across the South. Hospital systems are closing, and then when those hospitals close, what's going on with the money? I want to know where the money is. I want to know who's benefiting from it. And as Jen spoke about earlier, we have a gold standard and a model for how to set these kinds of programs up because we've seen it done before, particularly with HIV. It was shocking to me when I first started looking at this issue, when I first came to BWHI. And again, because I come from the background of looking at HIV and have seen these pharmacies work, and then I would stay on calls and these policy calls, and people would be like, "That's not how it works for cancer." And I'm like, "What are you talking about?" And so we know that there's models of reporting requirements and transparencies that work. We know that federally qualified health centers and public entities are having to report and private hospital systems are not. And we want to see that level of transparency happen and provide recommendations for where that funding should go, who should be benefiting, what kind of programs could be put in place to address the disparities that you are seeing. It's really important that we push on that level of transparency and reporting.
Thank you so much, Dr. Udo. And I think that that's really kind of especially for those of us with some trust issues around this, trust but verify is a whole thing, right? Some transparency on where those dollars go really kind of matters. We have a question in the chat real quick that I do want to address. Yes, we are seeing hospitals and hospital systems closing across the South. We are also seeing them nationally in terms of kind of hospital conglomerates coming together under what's called the Certification of Public Advantage. And in every single one of those filings, 340B is cited. It also is cited as to why they're closing down in highly marginalized communities and moving to wider, richer, more well-to-do communities. So we've got some strong feelings about how some of these hospital closures are going and who's being served, because they're not going where we would expect them to go under these dollars. Dr. Williams, Lizzie, Robin, do y'all have some reform solution ideas and what you would like to see out of those that you'd like to discuss?
I saw you, Reverend Williams. If unmute first, if you'd like to go.
No, you can go right ahead. I'll go after you, Liz. Thank you.
I was just gonna agree with Dr. Uday, you know, transparency and reporting, but also some clarity in the program itself. You know, we get in some conversations, you know, this program, it's expected that that money is reinvested in these programs, maybe not necessarily required, with some of the language and some of the loopholes that are within it. And I think with any program like that, as you continue and start finding those things, those are things that can be reformed or looked at as well to make sure if that is the original intention, that that's stated more clearly, and so that it's something that can be followed up on with hopefully better transparent reporting, then we can see if that's happening. You know, and we do know like some community oncology centers are staying open and able to keep their doors open because of this program and serve their communities in rural, lower income areas as intended. But as we have been talking about, you know, that's not the case across the board. And if that is the intention of the program, how do we do that? And how do then we as advocacy organizations help support that? And Dr. Udo shared some great examples of like patient navigation and other charity programs and financial assistance programs, all these types of things in the oncology space that happen, comprehensive care, community outreach, those types of things. And as I mentioned before, really that patient engagement and creating those, using those dollars for the barriers that are local for that specific center, and getting that patient engagement and feedback and input there as well to make sure that this program is running as intended and as well as possible, and those dollars are being stretched as much as they can to serve and help the community.
I would add to that, and I want to just thank both of the panelists for what they just shared. In addition, we do a lot of our work, the bulk of our work is done through our community health workers, our health navigators. And so when I think about the on the ground approach, I think about the importance of continuing to organize letter writing, right? Campaigns to our local and federal legislature and their staff. The other major thing that I've seen make an impact is sharing real life stories, how this is really impacting the day-to-day life of participants and patients across the board, and elevating that on our social media platforms as well as in public events such as the one that's taking place today. I also think that it's really important to raise the public awareness through, you know, webinars, through educational materials, and that continuous media outreach, and then continuing to form and join coalitions of like-minded organizations to amplify the advocacy efforts. One of the unique pillars to our work is using our clergy pulpits on Sunday mornings, on Wednesdays, and throughout the week to really amplify the message, amplify what we need support on, amplify the need. As one of the trusted organizations in our communities, our pastors and our clergy members, they have impact. And when they stand behind the pulpit, the sacred space, or any faith leader, when they stand in their sacred spaces and amplify the needs with really clear points and facts, they get a return and they get heard and they get seen, and we see change happen. And so I think these kind of forums, as well as helping to educate all of those community members, our clergy members across the board, helps us to draw attention and continue to see the reform we need within our communities.
Jen, if I could, I would just add on and first say amen to the Reverend, because I used to have a public affairs firm and it was called Amplify. So I am in complete alignment with the importance of amplification. It brings me back to where I started at the very beginning, that I think, you know, hospital closures are a horrific outcome of a lot of complicated reasons and financial reasons and workforce reasons, and very complicated. The solution isn't to partner with contracted pharmacies at the expense of patients or the nonprofit status. And so there are really important solutions, and working together with new technologies, with the evolving role of the pharmacist. Again, back to Script Your Future, we're looking at other members of the health team that might be able to help where there are gaps, not substitute for, but to assist. Working with community members and so on and so forth. These are only going to get more complicated as we have, you know, family members living longer. All of the social determinants of health are tricky. I will tell you that in terms of specific solutions, bringing it back to 340B, and using the advocacy of all of the groups on the phone and listening in today, you know, I welcome them. We are collecting them because we use them in our advocacy. Specifically, there are bills in Congress. The one that was introduced, I know I'm going to leave out one of the members. I think it was Buddy Carter and Bouchon, and I'm leaving out Diana Harshbarger. I probably butchered her name, but there is a bill that we think is a very good solution to this issue, because it's comprehensive, because it starts to minimize the confusion. It tightens up the definitions of patient for whom this program is eligible. It tightens up the contract pharmacy arrangement, the hospital eligibility criteria, and it goes on. And it's comprehensive, which is critical. You can't just take off a piece of this. At the same time, the nature of this is, I think, the PBM reform work that's going on, bipartisan. Actually, one of the things that might see the light of day, believe it or not, even in a lame duck this year. So, you know, there's always hope. And I think we're working at it at multiple ways. The bottom line is there are people that need their medication, and we all have a responsibility to figure out a way together. We're not looking to harm the hospitals at the expense of the patients, but the hospitals have to quit with this ridiculous denial of care because someone can't afford the care. That's not an answer either. We know times are tough in hospitals. We want to work with them to help get things back right for the entire community, but not on the back of the people for whom the 340B was set up. They're different issues, they're related issues, but we need to solve them together. And, you know, I welcome working with any and everyone who is like, you know, looking to do this. So.
Well said, Robin. Well said.
Thank you.
Fabulous. Everybody's been great. And so I'm hearing some common themes, and it's certainly in alignment with where CAN stands on these issues. So where we think 340B might be leveraged to help move forward and close some of these health equity gaps, and where it's not right now is dealing with patient medical debt, charity care, things like that. Creating some transparency where it doesn't currently exist. So grantees are required to report transparently to HRSA, but non-grantee covered entities like disproportionate share hospitals and contract pharmacies are not. So creating some transparency and accountability there. And then kind of like curtailing PBM rebate capture that comes at the expense of those grantees and covered entities to make sure that they're receiving the full benefit of those rebates. And lastly, to make sure that all of those dollars are being reinvested in extending program, whether it's helping with case managers, free, low-cost, discounted medications, food, transportation, all of these basic needs that communities in need have, making sure they get them at the fullest benefit of this program. So I want to take the last few minutes here to give everybody an opportunity to talk about their advocacy campaign on 340B and what that looks like. I'm going to drop into chat an ad that Can put together from direct patients who have benefited from 340B, asking the question, what about me? I'm going to welcome our panelists to offer their resources as well.
Well, at National Consumers League, we have a website, nclnet.org and scriptyourfuture.org, and we have resources. We are at the very beginning of a pretty in-depth analysis of some specific data on medical debt. We're teaming with other partners in this space because there is a lot that can be done on that issue immediately that can start to tackle some of that. And we're looking at that, also tying it back to 340B. We are looking to partner with folks to help push through the piece of legislation that looks to comprehensively reform. I know ASAP 340B is working on this as well. I don't want to speak for them, but you know, certainly I'm happy to put anyone in touch with the folks there. They're doing really excellent work, and would welcome the opportunity to just, we're open to all kinds of interesting, innovative ideas, but at the end of the day, we can't have people missing out on the very medication that is meant for them because the covered entities, whether they're hospitals or PBM, are profiting off of people who can't afford the products for which this program was established.
Yeah. One of the things that we have been hearing a lot about is that private sector entities and other sort of private care companies are saying that they do not know how to reach the communities which are most vulnerable. So ask us. That's what we do. Call on us at BWHI if you want to know how to reach and serve Black women, if you want to know how to reach and serve and take care for our families, if you don't know how to create language and communication tools and strategies so that you can not say that you don't know, then reach out to organizations like ours that know fundamentally what it means to talk to Black women, to talk to our families, to understand our stories, to hear why it is that we have such challenges with what the Reverend said about making decisions between buying food and taking our medications. There's a reason why that's happening. No one wants to call it. I'm just going to say it's structural racism. And so when you say things like, you don't know how to talk to us, then talk to us. So I'm happy as a head of, as a supporter of the a lead person in the organization, support you in those kinds of communication strategies and tools. We have a couple of them that we've put together that we can share with folks in terms of thinking about specifically how to use 340B resources. But don't ever say that you don't know how to reach us.
From a Choose Healthy Life perspective, we are continuing to call for reform. And I think that that is what the loudest message is across the board, right? And to really ensure that it realigns with the mission it was created for, and ensuring that there's compliance to that, and reducing the exploitation of the large healthcare providers and pharmacies. We've got to really ensure that reform is the message and that that realignment is there. And we're also meeting as often as we can with policymakers to ensure that they are prioritizing the well-being of our communities that are relying on 340B, because that's the way to ensure that the resources really reach the people that it was intended for. And so we think that is very important. And then just the importance of that human-centered approach. I agree with Dr. Udo, where she talks about the fact, stop going around and acting like you don't have an answer. Ask the people that are impacted and affected and you will get the answer, the clear answer. And so to continue to walk around as though you can't get in contact with the people, I have several mics that I can provide, along with several members in our community that can give you the straightforward account of what's taking place. And I think that, you know, we have to continue to really amplify what is needed and necessary for all of us as people in general across the board. Human rights is really what I consider the true step of prosperity. And so if we're not receiving the needs, the care that we need across the board, then we haven't really done the job. And so I think that from a Choose Healthy Life perspective, we're ensuring that our clergy are educated, that the mic is turned all the way up, that the message is loud and clear. We're educating our community. We're educating our congregants as well as the community. And we're doing that on the groundwork to make sure that we're helping to move towards the reform. Thank you.
Dan, I just got taken to church. That felt good. Thank you, Reverend Williams. Thank you, thank you, thank you. That like, I can't wait until we get some face-to-face time. Lizzie, do you have a final ad for us?
I would just echo everything everybody just said and add, here at Tiger Lily, we have a couple resources. We have an angel advocacy program, which is for patient advocates. Anyone wanting to be an advocate can enroll. It's free. We have free training. We talk about and look at how we can address as advocates structural racism, medical racism. We provide information about issues like 340B reform, PBMs, PBM reform, all these types of things that affect patients that are kind of invisible. That's probably the biggest feedback we get from community members and patients when we educate or provide information on webinars like this. They had no idea, you know, is my hospital a 340B hospital? Am I getting a discounted drug through 340B? I don't even know. And so I think that's really important, that piece of education and being able to plug in and get resources and people to empower themselves to share their stories, to speak up, to be involved in these kinds of conversations. As Reverend Williams was saying too, you know, we just need community members and patients to continue sharing their stories, and that's what we do at Tiger Lily. We're here to amplify and lift up those patient advocates. We also have resources that are provider facing and patient community facing, barrier toolkits, talking about financial toxicity, you know, lack of portrayal in media, lack of representation in the medical field, things like that across all the boards, the board of social determinants of health. We also have a program called RAISE. It's for patients to be able to use specifically to raise funds and support during, before, during, or not during and after treatment. And so it's a great way. It's kind of a GoFundMe meets a registry. There's like a private piece where you only people you know, things you need, like come to my house, help me with dishes, take my kids to school, walk my dog, versus financial needs that anybody can help with. And so those are some resources I think in general there for some of these issues, but I would just call on everybody and reiterate on the patient community side, please get plugged in, share your story, let us help you amplify your voice, any of us here on this panel. For everyone else listening on the healthcare side, whether you're a provider, healthcare system, policymaker, a pharma industry, please engage patients. Just thank you, Dr. Uday and Reverend Williams for sharing that. Tiger Lily too, happy to raise our hands and help with that. But it takes all of us coming together to co-create these solutions, to create programs that are actually going to benefit patients and especially affect health equity and bring us closer to achieving health equity. So thank you.
And journalists, sharing the story with the journalists who are looking at these issues. They always want patient stories, and it's hard to find them for the very reasons that you said. Patients often are not aware about the mechanics of PBMs and whether a hospital is 340B and so on and so forth. Doesn't mean they can't learn. It just means, you know, they're busy trying to stay alive, and so they have other concerns. But media can be very helpful as well.
Absolutely. Elevating patient voice and advocate voice in this is really like a key tool that we've got to build on. I do want to go ahead and wrap up. We are at time. I want to say a giant thank you to our panelists. Y'all have been wonderful, and especially in bringing different perspectives and highlighting where 340B is currently operating, kind of like a double-edged sword, and where we need to be bridging those gaps. There is a question in the chat real quick, and I want to address this real quick, Alex. We will be following up with the information captured and making sure folks got the resources that were in there, have follow-up emails, things like that. I know there were questions that we didn't get into. I want to take a moment to end this on a giant thank you to NMQF for hosting this webinar. It was wonderful. Y'all did such a fabulous job in putting this together. And thank you to our sponsors. Everybody, I hope you have a great day. I hope you stay dry if you're in a wet area, and I hope you stay cool if you're in a hot area. Thank you so much.
Thanks, Jen.